coming to our in-person lab course on manual lymph drainage. My name is Kristen. I am a doctor of physical therapy, and I got my MLD certification about a year ago. And then we also have Carrie.
So my name is Carrie. I've worked with the company since my son was born. He's now in high school, so that tells you how long I've been here. I got certified in complete lymphedema therapy about 5 years ago. It is a 10-day course. We're not going all through that today, but we wanted to take some of those techniques that we both learned and apply them to the patients that we see here.
So the first question is, what is lymph made of? Answer A, water, B, protein, C, tattooing, or D, all of the above? All the above. Good. Very good. Yes, all the above. So if you guys remember from the video, lymph can be involved with anything. So anything that you take in during your day can become part of your lymph, and that's what makes your lymph more viscous or more thicker. So like think of like hairdressers, they're like breathing in aerosols all day. Nail artists are breathing in acetone all day. Construction workers breathing in debris. All of that goes in towards your lymph as well.
So what are the contraindications for manual lymph drainage? So who don't you want to do any of these manual techniques on? Go ahead, Mike.
Probably C.
Nope.
B.
So if you have Raynaud's, you don't want to wrap or put compression because they have arterial insufficiency, and so they have areas where the blood has difficulty going. You don't want to put compression on those patients because you don't want to compress when they already have difficulty with their circulation. However, you don't want to send fluid to the heart if their heart is already swollen because the heart already can't handle what they have.
So what are the benefits of manual lymph drainage? A, improved circulation, B, pain relief, C, increased lymph angiomotoricity, or D, all of the above? I think I heard someone say it's D, it's all of the above, yeah, for obvious reasons.
All right, what is true of edema versus lymphedema? Edema is due to a mechanical insufficiency. The lymphedema is a disease that can be due from damage to the lymphatic system. Edema requires lifelong management, or D, lymphedema is due to dynamic insufficiency where the system feels overwhelmed.
B.
Correct. So remember, edema is a symptom of something else. Lymphedema is a disease process. I'm not teaching you guys how to do lymphedema in this course because, like I said, it's 10 days, it's lifelong management. You have to treat lymphedema every day, in the morning, in the evening. It unfortunately encompasses your entire life. But we can use some of these skills to get rid of the edema in our patients that are swollen, get their pain away, get their range of motion better.
And so for the last question, it's going to be true or false. The lymphatic system is a closed system, which is why MLD helps with movement of fluid. Is that true or false? False, right. So remember, the lymphatic system is an open system, which is why our MLD techniques actually work. And then an example of the closed system is your heart, because your blood can only flow one way through the entire body, and we can't change that. All right, so we're just going to do a quick review, even though we kind of just reviewed it through those questions, but just super quick of what you guys kind of went over. This is just some of the important stuff that we kind of thought would be good to just bring in right before you guys actually start doing the techniques.
Perfect. So I like to think of your lymphatic system as the other half of your circulatory system. We all learned in school that your circulatory system carries blood, to the body and then back to the heart, to the lungs. Beautiful. But the circulatory system only carries 80% of the fluid. So there's a 20% left of fluid that your lymphatic system is responsible for. And if you remember way back when, blood travels from your left ventricle to your aorta, to the arteries, to the arterioles, to the capillaries, and then through the veins, vena cava, right atrium, right ventricle, to the lungs, left atrium, and then back to the ventricles. The system is closed, like Kristen said, because the only place that blood and nutrients can go through is the capillaries. The rest of the system is closed unless, of course, there's an injury and you're bleeding, which obviously is not a good thing. The lymphatic system is to take the particles that are too large to fit back in your capillaries. Capillaries only release things that are like one cell space. Some of your broken down proteins and those kind of things won't fit back into your circulatory system, so it's your lymphatic system's job to carry that back up into your heart. All right, so then we just wanted to give you a little picture of the anatomy. Your lymphatic system is made up of lymph and lymph nodes. You have about 650 to 750 of lymph nodes in your body. You have anchoring filaments that attach to your lymphatic system to your skin. It's because of those anchoring filaments that we can apply pressure and to affect the lymphatic system. Again, we talked about the open versus closed system. We're going to use the lymphatic system. We're going to stimulate it to bring more fluid back to the heart and then eventually to the kidneys and out into the plumbing system and out of the body.
So then again, just the purpose of the lymphatic system. Again, as Carrie just said, we're just trying to move bigger particles that the rest of our capillaries can't. It carries a lymphatic load. Lymphatic load is everything that we just talked about in those questions. So it's everything that your lymph fluid can carry, and that can make it more viscous and harder to move, which is why you will see swelling actually accumulate on a person's extremity. Again, same thing. It's made up of all these different things, plus everything else that you guys breathe in through into your environment as well. And the lymphatic vessels are everywhere in our body. They're in your hair follicles, everywhere. But they are on the surface level of your skin, which is why we are actually able to make a change to the lymphatic system, and which is why we had you guys wear shorts and tank tops today, because we need to be able to be on skin to actually make an effective change on the lymphatic system. Okay, and then so just quick contraindication, just because this is a lab, just to know who you guys should not be doing these manual techniques on. And again, so pretty much anyone with any kind of like organ failure, those organs are already stressed. So if we try to bring more fluid to those organs, they can't handle that increase in load. So we don't want to overstress a system that's already having an issue, okay? And then obviously any kind of like active cancer malignancies, fevers or infections, because we don't want to spread those to other regions of the body. Same thing with open wounds. If there is an infection somewhere, now we don't want to move it to an open wound either. And then short walks can cause shortness of breath. So if you even have someone who has like, I don't know, COPD or whatever else, that person already is struggling to breathe. So if we, again, bring more fluid towards the system that's not working well, then they're gonna have an even harder time breathing. So just like even those little small things that you don't think would affect something like this, it really actually does for somebody. And then contraindications for compression, which we're gonna go through in the last part of the lab. It's pretty much kind of like the same thing. So anyone, again, cardiac edema, because we're pushing fluid up with the compression, their heart can't handle it. Ray nods for what Carrie just said. Decreased sensation, because if they can't feel how tight something is, they may actually be putting something on too tight, and now they're cutting off their circulation. So always keep in mind for that. And then any other kind of cardiac issues. We just want to kind of be aware of how much we're taxing somebody's system. Okay, so the first breakout we're going to do is in your lecture PowerPoints. We talked to you guys about the different strokes that can be used for MLD. So there's 4 different ones. There's stationary circles, there's pumps, there's scoops, and then there's rotaries. So just to let you guys know, we're going to show you the rotary one today, but we don't typically like ever use it in the clinic, just because we're not typically treating those kind of like injuries or body parts that rotaries would be used for. So we'll show you, but we're not really going to practice them. We're really just going to focus on the other 3. And then this is just important on how to perform your different strokes. You guys want to make sure that you're using your MCPs. So you're using a flat surface at the tip of your hand here. And you want gentle pressure. So remember again, I said if you put too much pressure, now you're actually closing off the lymphatic system, because that's how close it is to the surface of your skin. You want to make sure that there is a 3 count held during your 2 different phases. So you have your working phase, which will hold the 3 count. Then your resting phase is when you guys actually take your hand off the person's extremity, because we don't want to push fluid back to where we just tried to pull it away from. So that's why we release the hand completely, and then we come back down to the person's seat. And we do it 9 to 10 times per spot, because you want to make sure we get at least 8 good ones, just in case maybe you pushed too hard on one of them or you didn't do it good enough. At least there's some counterbalance there to make sure you're getting enough strokes to actually help push fluid through. And then again, wear loose clothing or have your patient change, okay? So the first one we're going to start with is stationary circles. This is the one I probably use the most in the clinic. So again, we're going to be on skin, on MCPs, and I'm here, and I usually always do, so you're going to always, we'll go over this later, but you're always going to start at the lymphatic site, which is inguinal here at the top, okay? But I'm going to show you guys here so you can see it better. So you guys are going to be here. You're going to always go away. You're going to open up the lymphatic drain first, and then you're going to push it up towards the drain, okay? So you're going to open, hold for 1, 2, 3, that's my working phase, and then I relax, that's my resting phase, and then I would come back here, up, and then rest. Okay, I don't want to push it back down, so that's why up, 2, 3, off. Up, 2, 3, off. Okay? And again, I would then do that 9 times. So that's stationary circles. So this one I usually use on like the lateral side of the leg or usually the calf. But you guys can use the web space of your hand. And so if I'm on this side of him, I'm going to use my left hand. But I'll show you on the top of his thigh. So you guys are going to come down with your web space, open up the lymph, and then you're pushing up for 1, 2, 3, rest. Okay? So I'm pushing down and up, 1, 2, and down. Okay? So it's kind of like a down and up motion. Okay? So open up the lymph vessel, push it up towards the inguinal always. The other one's going to be scoops. This one we really only use on the calf because it's kind of hard to use anywhere else. So I'm going to have Scott bend his leg. For the scoops, again, you guys are going to start with your web space, but you're going to end up using like a fanning of your fingers at the back of the calf. So if I'm on the top here, I'm going to come around and I'm going to scoop and come up the back of the calf that way. So if you guys can't see that, just come over here. So I'm going to come scoop and then come up. Okay? And that scoop is where you hold the 3 and then relax. Come up, 2, 3. Come up, 2, 3. So you're actually covering more surface area through the calf as you do that because you're going to fan your fingers around the back. So you're moving it here and pushing it up towards the inguinal lymph drain. Okay? So the rotaries, you're literally making like a rotary like turn. So if it's their back, you're going to push the fluid either towards their axillary drain or you can push it down towards their inguinal drain. It depends on what's going on with that patient. But so you're literally going to be here and I'm rotating it towards the drain that I want the fluid to go towards. So if I'm here and I'm just 2, 3, 2, 3, and then that would just bring the fluid across this way. And stationary circles are just going to be open the drain, push it up, 2, 3, okay? Pumps are coming web space, down and drawing up, 2, 3, and then your last one's going to be a scoop. So I'm going to use my web space, come around and fan my fingers at the back. Okay?
Okay, so just because obviously you would use this technique if you were treating a lymphedema person, I wanted to show you what it involves if someone actually was coming with you who had lymphedema, whether from breast cancer surgery or whatever. You start with draining all of the key lymph nodes first. So you want to clear the neck, you want to clear the armpit, and you want to clear the groin. Those are where most of our lymph nodes are stored, and you want to clear those first before you go to the other areas. Afterwards, you're going to go into the collectors, and you're going to pull all of that lymph fluid up from the extremities into the lymph nodes and then move it over. It's a long sequence. It takes about 40 to 50 minutes. You have, like we said, you perform 9 strokes at each of the areas, hoping that you get 8 good ones. And unfortunately, insurance doesn't always pay for things like this, so it gets a little bit complicated. But what we did is we narrowed this down to use it for our patients that have swelling after surgery and those kind of things. We did an upper extremity sequence and we did a lower extremity sequence so that our OTs can be part of it as well. So this is the 10 steps that we're going to teach you now. So we're going to take the strokes that we taught you and we'll show you where to use what strokes and how to use them. You're always going to start, whether you're doing your arm or your leg, you're going to clear your lymph nodes first. You want to clear these because you don't want to move fluid up here if these guys are already overwhelmed. All right? So you're going to do 9 times in the groin for the lower extremity and then 9 times in the armpit if you were doing upper extremity. For the leg, you're going to do 9 times. You're going to take the fluid from the front of the thigh, from your knee, up into the groin, 9 times. Then you're going to go from the outside, 9 times. You do have lymph nodes along your knees. You're going to do 9 times at your knee. And then you're going to do 9 times into the lower leg. And then you're going to do the whole thing over again. You're going to do 9 times here. You're going to do 9 times here, 9 times here, 9 times here, and 9 times here. You have to rework it to make sure that you get all of the fluid out. For the upper extremity, same thing. You're going to start here, then you're going to work the upper arm. The arm, depending on how big the arm is, you can actually get away with just doing one path. If they're more muscular, you might want to do the outside and the top of the arm. You're going to do the elbow, and then you're going to do the forearm, and then you're going to rework everything. 9 times here, 9 times at the elbow, 9 times the lower arm, 9 times in the anterior arm, and then 9 times in the armpit. If they have any pitting edema, you can use your fingers once you go through the sequence to actually push your fingers on either the hand or the foot, and you can actually see the fluid and use your thumbs to kind of push them out.
So for a patient, I always tell them I have to be up in your groin just to start the process. So I'm just telling them that I'm going to roll their shorts up as high as I can because you're literally in their groin, okay? And make sure you're kind of like in that inguinal space where the lymph nodes actually live, okay? So if I'm here, I'm going to do 9 times in just the inguinal groin first to open up that major lymph drain, okay? So from here, I do stationary circles. So I'm going to come down and up, 2, 3. 2, 3, 2, 3. Okay, 9 times. Okay. Then now I'm going to start working from here and working the fluid here and coming up. But I'm not going to stay in one spot. I'm actually going to do the entire thigh at once. Okay. So I can come here, 2, 3, 2, 3, 2, 3. You guys can use one hand if you want. You can go quicker and use however you feel most comfortable as you get more comfortable doing the techniques. Okay. But otherwise, 2, 3. 2, 3, so it's still the 3-second count, but I'm doing that up the thigh 9 times, okay? So that's anterior thigh. Now I'm gonna go lateral. On the lateral, again, you can still use your stationary circles. I could come down and up, down and up. I can also use my pumps though, so I tend to do here because it's easier to circle around the calf, to come down and up, down and up. So I'll do this leg too so you guys can just see. So I could either do here and up, or I can do up, all the way up for the 9 times, okay? So that's 9, 9, 9. Now you're gonna do the knee joint. So you guys are just gonna have your SCPs right on the edge of that joint line and you're coming down, up, 2, 3, rest, down, up, 2, 3, rest, down, up, 2, 3, 9 times, okay? Then I'm gonna come to his calf. Again, I could do any kind of hand I want here. Scoops are more surface area. And I'm coming up the whole leg 9 times. Okay. Normally I would also have their shoe off. If they're typically swollen anywhere in their leg, typically you guys also see it in their foot too. We don't actually do the MLD to their foot, but I can do some effleurage. If there's, like Carrie just said, if there's pitting edema in their foot, I can effleurage it out of their foot, up to the leg, because now I have to repeat my process. So whatever effleurage I just pushed out of the foot to the leg, I will now be able to get back up to the groin during my second time back up. Okay, so if I just did my 9 times here, I can do some effleurage to their bare foot, just get that fluid up. Now I'm going to repeat my process. Okay, so I'm going to go another 9. Okay, let's just say that was 9. And then I'm going to come back to the knee joint. Okay, so that was 9. Then I'm going to go lateral thigh again. And then I'll do this one 9 times. And then anterior thigh. So starting distal and always moving that fluid proximally.
Alright, and then you work backwards.
And then one last time, end at the groin again, and do 9 of them. Remember, on top of that inguinal groin region. And I stay just here for 9 times. Okay, so that's why it takes so long, because you have to do the whole thing 9 times in each spot, and then you have to do it again. Okay, so that's the whole sequence: groin, anterior, lateral, knee, calf. You can do effleurage if you need. Calf, knee, lateral, anterior, groin. Okay. So for the shoulder, because we have to start in the axillary, you literally have to be in their armpit, okay? So if the patient can, it's not against protocol or anything like that, we're gonna put their arm here. We're gonna open up that, that drain, okay? If there's precautions for whatever reason, they can keep their hand down at their side, and then you can just try to get them to wherever you can, and then just getting into that armpit, okay? So if I was gonna treat Scott's left side, I typically stand on the opposite side of the patient because it's easier to come in here and do the pushing down and then trailing up. So I'm gonna have to put your arm over your head, just so they can see. So I like to be here, and then when I finish the arm, I'm gonna come around to the other side of the table and I would finish it off, okay? So I'm starting in that axillary, like really be up there. And again, you're doing the same thing that you did in the groin there. You're gonna come down and up, 2, 3, release. Down, up, 2, 3, release. And you're doing 9 times just there first, okay? Then you can bring their arm back down, because now we're gonna go, again, Carrie said it earlier, but depending on size of the person, size of your hands, you can do anterior and lateral. If they're a smaller person, you could probably get away with just doing one motion onto the arm, okay? So I'm gonna do it here just because I'm on this side. But for him, I could do stationary circles here. So I can start from the elbow. I just opened up axillary, right? So I can start from here. Now work my way up, just like I did on the femur, okay? So if I'm here, 2, 3. And I'm gonna do that 9 times. Okay? And then I can come to his lateral side of his arm. And I could do my pumps. I could stay with stationary circles if I wanted, but I could also do my pumps here. So coming down, up, and then that 9 times. Okay? But again, you can do stationary circles too. Then you're gonna come pupil fossa. So here, same thing you guys did with the, I'm gonna raise your arm up just so they can see it. But same thing here. So I'm gonna take MCPs on this joint line. I'm coming down towards the table, up towards the axillary. 2, 3, release. Down towards the table, up towards the axillary. And then you'd stay here for 9 times. Then you got forearm. The forearm you can typically just do in one sweep. So you can do scoops just like you did for the calf. You could probably also get away though with your pumps, because forearms are typically small enough your web space should fit around there. So I'm going from wrist up to elbow 9 times all the way up. If there's a ton of swelling in the hand, I can effleurage. This one you don't have to be gentle with. You can push that, any of that pitting edema out of that bottom of the extremity, because now that we just pushed it up here, I'm gonna help work its way back up, okay? And then I would come, you can do that as much as you want, doesn't matter, 9 times, 12 times, whatever. Then I'm gonna come back here, up to the elbow for 9 times. Okay, let's say that's 9. Back to cupula fossa, so just so you guys can see. Down and up. 9 times just here. Okay. And then back to the arm. So I'm on the lateral side, working my way up. You're gonna do 9 times. And then I got anterior arm, starting from distal, working that fluid proximal towards the axillary. You can also do a hand over hand approach here.
My teacher said do not put your hand in the first place.
Okay. And then lastly, again, you would end with axillary, however you can position their arm. I'll do it on this side again since I'm over here. And then ending that last time here, down towards the table, up towards the axillary, holding for 3. Down towards the table, up towards the axillary for your last set of 9. Okay? So just to repeat, axillary, open it up 9 times. Anterior arm from elbow up. Lateral arm, elbow up. Elbow 9 times. Wrist to elbow 9 times. If you need to unlock your hand, repeat. Wrist to elbow, 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 forearm, shoulder, and then axillary. Alright guys, so for our last breakout tonight, we're just gonna go over compression and taping. We're gonna show you guys, we're gonna do KT taping for you guys for upper and lower extremity, but we're just gonna show you the other different types of compression that more so like a lymphedema patient would kind of use. So these are just some examples of what the KT tape could look like. So in your online presentation that you guys watched, we talked about covering as much surface area as possible with the tape, and how the tape kind of does the same concept of what we do with our hands. So the ridges on the back of the tape, that's what I always tell my patients are like the magic in the tape, because that actually helps grip the skin and pull that gentle pull, which is why we always do it after we then perform the MLD, just to kind of help that fluid continue to move up towards the drain. So I'm just going to show you guys this here. This is the top of the drain. And then these pieces, the longer pieces that are covering the leg, are bringing it up towards the drain that way. Does that make sense? So you're always going to do, this is called your anchoring point, is always going to be at the top of the drain, and then you're coming upwards that way. Okay? Alright, so this kind of basically just goes over what I just said. But we're just going to show you like the different compressions. So these ones, these huge ones, these are for true lymphedema patients, and they're going to sleep with these all night long to help keep their compression moving throughout the night, but it's not as tight as the really tight compression garments that they can wear throughout the day, because they are never not bandaged or compressed, because remember, they have a mechanical insufficiency. Something is broken, okay? So that's what these big ones are. I think this is an arm and a leg, possibly. So you guys can come feel these around later when we break out into the groups. This one is a compression garment, okay? This is medical grade. You usually need a script ordered from a doctor. The script can be sent to a PT. You guys can take measurements of the limb, and that way you know what size to order. This one was what, 20 to 30? This is a 20-30 to size, so this is actually kind of small, okay? But this provides a stretch all day long because it's thicker and tighter. So you guys can kind of feel that later. And then we also just wanted to show you the difference of the short versus long stretch bandages. So I'll go long stretch first, because this is what you guys are really going to see like in clinic. So if you guys ever have like the tensile grips in your clinic, they all come in different sizes, right? You can kind of go based off the size of your patient's limb. But this is long stretch, right? So as your patient moves, the bandage is going to stretch with them to help fluid continue to move, right? And eventually this gets so stretched out that you need to give the patient a new one, right? The short stretch bandage is, this is not an ACE bandage, by the way, but an ACE bandage is the same. Short stretch, long stretch, it stretches with the patient as they contract the muscle, right? So if you were to squat with it on, it would expand with you. This one will not. So this is short stretch. See how like that's not going anywhere else other than that? And you guys can feel it when we break out into groups. So this does quite the opposite. So if you're going to move, this is going to continue to compress to help bring fluid up. So as you move, this gets tighter. Does that make sense? So these ones we're not typically using, but true lymphedema patients are using. So in the clinic, we're using KT tape and then the long stretch tensile grip. So for KT taping, I usually measure from the extremity for the patient. So I'm also not going to do a strip from here and come all the way down the leg. I'll most likely do two if I need to do something like that. So I could anchor here and strip it down to the knee, and then do a second one where I anchor from the knee and then come down to the calf, okay? And also, like, if you just have like your lateral ankle sprain who has a ton of acute swelling, like you can do just the lower leg for that person too, okay? Because nothing up here is broken, they have an acute injury here. Does that make sense? So for her, I'm just gonna do her lower leg so it's a little easier. Okay, so I take a shorter measurement because then I'm gonna stretch, right, because it stretches. So here, we round our edges so that it doesn't get caught on our head. And then, so that's my anchor here that I just rounded that edge. And then I'm going to cut like little spider webs basically from the bottom up. So just to make it easier, I usually fold the tape in half. And then leave a spot for your anchor. Okay? And then you can cut from here.
And then I hold this down.
And then I just cut till I get to the end of that piece there, and now that piece will fall out that way, right? So I try to get at least 4 of them if I can. And then I will also do, you're gonna do 2 of them for her lower leg. Because remember, we're trying to cross as much surface area as possible. So if I were to start this one here, Then my second one I'm gonna cut is gonna start from here and come all the way over. So I'm just gonna cut another one really quick so you guys can see the whole thing. So now I usually start by just ripping the spider legs off the top of that anchor point so that all I have to do is pull this one off and now the rest of them don't get stuck to anything. And I'm gonna start at the top of her knee here, at the drain here, and I'm just gonna anchor it on. You don't have to stretch it or anything, it's just an anchor point. So all you can do, you can just lay it down, okay? And then I'm gonna do one spider leg at a time and trying to cover as much surface area as possible. So it can wrap around the back of her calf. So if I take this one off. And this is gonna come around. Just look to it, you bend up your leg for me.
You want to cover as much surface area as you can because, like Kristen said,
You're gonna put like 75 to 100% stretch on this. And if they had the swelling in the foot too, make sure your strips are long enough so that this can cover the dorsum of their foot as well. Because that will also help whatever fluid is there come up too.
Could you do separate ones for the foot, or would you recommend trying to extend?
Extend them out. Yeah.
Yeah.
Unless you have like a lateral ankle sprain, that's something different.
Gotcha.
Okay, so then now I'll take my other one, cut the legs off. And now I'm gonna anchor starting on this side, and I'm gonna overlap as much as I possibly can on those 4 strips that I just put down.
If they're really swollen, I would use this over the sleeve. I use this and then put the sleeve on. And then both, because one the sleeve will help both sleeve on.
So this one's long enough, I can wrap around her leg there.
This sleeve lasts a day, this sleeve lasts 3 or 4 days. So if it doesn't sleep great, you want to put the sleeve on to give it a little extra. Because remember, all of these patients have good sensation and they don't have any circulatory issues. So I'm not worried about that.
Don't do that.
My biggest complaint, and we won't mention who, is the doctor that doesn't utilize this, sir.
See how that one was long enough to actually come to her foot? So as much surface area as you can possibly get to help open that up. So this is gonna literally just reiterate what you already did. After I tape them, I usually also put the tensile grip over them, just another line of defense to help bring that up. And I usually tell them not to sleep with the tensile grip though, just so that they're not compressed all night long, because there's not something dynamically, mechanically wrong with them. They're just swollen from whatever injury they acutely have, okay? But the tape they can keep on for as long as they want until it starts to roll up and fall off, okay? And taping, I also teach my patients how to do at home. They can buy tape online and then they can tape themselves too if they want. But that's what it should look like, and then the same for the arm. It's easier to cover more surface area on the arm, obviously it's smaller. So on the thigh, make sure that you guys are really getting up into starting the inguinal, and then you guys can also start like almost like around like greater choke for that second piece, and then come all the way down and around that way. We're just gonna show you guys like how to document. We typically build 1 unit of manual therapy for this treatment, and like education and all that stuff. So we're just gonna show you documentation examples.
Perfect. So basically, I just, you want to obviously take range of motion measurements. You can do before and after the treatment. Sometimes patients will have increased range of motion after. Sometimes you can't get it that fast. You can do girth measurements. You want to make sure that you write down where you're taking those measurements, because if you do from time 1 and time 2 and you do it from different places, you're not going to get the reliability. Or if I treated the patient once and then Kristen's teaching it or treating the patient the next time, you want to write down where you took those measurements from, so Kristen knows where I measured, how I measured, those kind of things. And then of course you always want to check pain, and you can do before and after treatment. It is a very manual, relaxing treatment. You guys hopefully felt good afterwards, so it should take some of the pain levels down, especially if the joint's really swollen, irritated, and those kind of things. All right, so this was a little assessment. Kristen is the documentation guru. So patient presents with considerable amount of edema to the left lower extremity following his total knee replacement. Patient presents with 1+ pitting edema. Remember from the slide, the pitting edema has how far, when you put your thumb indent, how long it takes for the swelling, for the pitting to come back up. AU of 7 out of 10 complains of feeling heaviness or tightness. Usually when you're swollen, that's what the patient will complain about. The limb just feels heavy of the limb, and then his pants feel tight. Patients present with painful and limited active and passive range of motion for knee flexion. I will write down, and Kristen will write down, performed a modified MLD sequence either to the upper or lower extremity, depending on where you're working on, to open lymph vessels and accelerate lymph flow, to reduce edema, decrease pain, and improve mobility of the left knee. And then if you wind up using any applying tape, was done with anchors beginning at the left hip to the knee, and then left knee with the tails down to the foot and ankle with as much overlap as possible to help draw the fluid up. Or you can always, I talked to my group, I'm sure Kristen did as well, you can also use tensile grip over the tape. Sometimes tape doesn't stand on very long, it has to do with oils in the skin or whatever, so sometimes I will slip on a sleeve over to keep it to last a little bit longer. And patient is educated, you want patients to drink lots of water afterwards. Remember, we're trying to flush all of this stuff out, and sometimes when people are swollen, they stop drinking water because in their brain they're like, well, if I have too much water here, then I'm not going to take on more water. But you actually want them to drink as much water. And then, of course, elevating ankle pumps and home exercise program. And upper extremity, kind of the same thing. Patient presents with considerable bout of edema to the right axillary and pectoral region following her subscap repair and bicep tenodesis. 3 weeks ago, patient presents again with +1 pitting edema and severe pain, 8 to 9 out of 10. Patient presents with painful and severe guarding with passive range of motion of right shoulder, especially with flexion and external rotation. Performed, again, a modified sequence of the right upper extremity to open lymph vessels and to accelerate lymph flow, to reduce edema, decrease pain, improve range of motion of the shoulder. And the same thing, if you want to provide tensile grip over the arm to decrease swelling and pain.
Now, there's just 5 questions, and it's literally just what we've learned in lab today, so nothing with the video that you guys learned.
All right, how many strokes do you perform at each spot? 9. Very nice. What part of your hand is best for performing the MLD strokes? You got it. You guys learned stuff. All right, true or false? The 2 different phases of performing MLD are the working and resting phase.
True.
And what are the 4 different types of strokes?
What's the one that's missing?
Rotary.
Yeah.
All right, what kind of education can you provide your patient for home? All of the above. Yep. You can't teach them how to do it themselves. It takes a little bit of practice, but you can do it.